Great. Well, thank you again, everyone, for joining us today. We're looking forward to having a very informative webinar on the effects of patient education on healthcare quality and ACOs. This is Cindy Carson. I'm the National Director at Milner-Fenwick, Education for Better Health. For those of you who are new to us, Milner-Fenwick is the leading producer of quality patient education videos in the health education market for over 40 years. We'll give folks a minute more as they join in, and we'll go through some basic introductions. We're pleased to have with us as our guest presenter today, Dr. Stephen Merahn from Clinovations. Clinovations, as you can see here, is a strategic advisory and management consulting service at the Center of Care. And Dr. Merahn is the Senior Vice President at Clinovations, Director of the Center for Population Health Management. As a veteran physician executive, Dr. Merahn has deep experience in healthcare quality and performance improvement based on the adoption and integration of clinical information technologies and analytics, healthcare interaction design, systems innovation, clinical transformation, evidence-based care delivery, and program development strategies. So in today's discussion, we'll be looking at the role of the right patient education as an ingredient in successful population health management and accountable care delivery. Specifically, we'll take a look at how education is supporting patients and taking an active role in their health, closing the care transition gap from hospital to home, and streamlining provider-patient communications, which all lead to better health outcomes. Our mission today to discuss how patient education drives better health outcomes and supports accountable care models, specifically readmission reduction and cost savings from better patient compliance and adherence to care. Also look at how providers can leverage quality health education to meet broad ACO goals. So we've got a lot of deep content to get through, and it looks like we've got enough folks signed in here. We'll go ahead and get started. So as I mentioned, we have with us today Dr. Stephen Merahn from Clinovations. So welcome.
Thank you.
Stephen, great to have you. Again, thank you so much for joining us today. If you want to say a few words before I start peppering you with lots of questions.
Sure, no problem. Well, first of all, I want to thank everybody for taking some time to join us today. I'm a physician, a public health physician by training. I spent 7 years with the New York City Health Department working with a diverse set of populations, and over the years actually have come to understand from my time in public health that communications and education are in fact as powerful clinical tools as are some of the drugs that we prescribe. I was lucky enough before I went to medical school to have as my mentor someone who was a professor of biology, but he happened to have gotten his PhD in science education. So he really grounded me in the importance of communication skills in achieving knowledge, attitude, and behavior change. And I think while over the years the general medical community has always thought health education is important, I think with what's happening now with healthcare reform, we're not only seeing that it's important, but in fact in some cases it's mission critical, or at the most extreme cases today, it's actually being built into the contract for what we have to be accountable for in order to be compensated for care. So I think the role of patient educators, communicators, I don't want to get bogged down in the titles, but there's a whole group of people from a diverse set of backgrounds who are really committed to working with patients at this level, and their roles are going to become far more important in the system than I believe they've been to date. So with that, let's get going.
Excellent, excellent. Well, given your background and your work in population health and value-based care, can you sort of give us a foundation for today's discussion by defining population health and accountable care?
Sure. And I think we have a slide for this. I think just everybody knows, I gave Cindy a bunch of slides, and she picked and chose which ones I'm going to see. So let's see if one of my slides made it into the deck. But one of the big differences between population health and what we do today, and let's just take what we do today in terms of, let's call it fee-for-service. In fee-for-service medicine, the patient self-selects. Oh, I have a rash. Oh, I have a headache. Oh, I fell down and there's blood coming from my leg. I need to do something. I need to take action. And the patient self-selects for care, and they go in, whether it's to their primary care doc or to the emergency room, or they have to call an ambulance. Whatever reason is that for transport, the patient actually at that point self-selects for care. And they come in, and they have a bunch of services provided to them, and the bill is based upon the things that are done to them or for them. In population management, we flip that a little bit, and rather than say that the patient has to self-select, the professionals who choose to take on responsibility for a population analyzes that population and sees where there are people who are well, people who are moderately risk, people who are at high risk, and devise a collaborative care plan with those patients. They reach out to them, they engage them, they say, I'm going to take some responsibility for your care, even, by the way, if you haven't come into my office in the last year, but I see based upon the data that's available to me that you have these conditions and you've been on these medications. Let's assess where you are in terms of the status of both the care you've been getting and the quality of your health. And then everybody gets a care plan, and then the care plan gets acted upon. So my goal as a physician is not as much the care of individual patients, although it remains care of individual patients, but at some point I'm going to generate a report card for how I'm doing across the entire cohort of patients. Now, why is this important? Thanks for the next slide. Is because this changes the way people are paid. Rather than me get paid as a physician to clean your wound, dress your wound, stitch your wound, and then get paid for the follow-up visit, so rather than get paid for those pieces, the services I provide, I'm going to get paid a little baseline for the entire population. And if I hit my goals, if I get A's on my report card, I get a higher set of compensation. So, oh, this is perfect, thank you. So here's an example of future value. Patient A chooses to come in, and they have a payer, one insurance company, or their employer pays that pays for that patient. And another patient may work for somebody else or have a different insurance program, a state-based insurance program, and patient C may be on Medicare, federal government program, and so payer C is the federal government. And basically, I come in, and as a doctor, I've got to send out bills to all these different payers. And then the payers are like, well, did you really do this? And we have to kind of figure that out, and ultimately I get paid something, not all of what I ultimately do. In population health, it changes a little bit. And what happens is I then say to the person who's contracting for care, whether it's what we traditionally call an insurance company or an employer, a plan sponsor, or the federal government or the state government, I work with those people that are contracting for care, and I make a deal. And the deal is I'm going to take care of all these patients either in my community or who work for this employer or who are part of this union. And in exchange for you paying me on a fee-for-service basis, I'm going to take overall responsibility for those patients. And every quarter or once a year, I'm going to give you, we're going to have a report card that will tell you how I did against the goals that we decided, because these are mutually decided goals. And Cindy alluded to one of those goals. One of the big goals right now, I'm sure everybody's heard this, is the idea of reducing 30-day readmissions, because they are, in fact, preventable. So now we're incentivizing, we're providing some value for providers and provider networks to say, oh, we're going to invest some staff against this idea of reducing readmissions, and in exchange, we're going to be able to give our report card back to the person contracting for care. And by either reducing costs or reducing hospitalizations or improving the quality of health status across the population, we get our kind of negotiated fees for the overall quality of health. Now, this is transformational because it actually creates a tremendous change in the system to focus on achieving quality goals independent of any one patient. The challenge is doing this requires all sorts of competencies that most physician groups and health systems don't have right now. So how do I analyze the population? How do I decide who I'm going to give care to? How do I reach out and communicate with these audiences? How do I assess whether my communications are adequate or not? Once I engage that patient, how do I make sure that I've effectively used the lowest effective level of resources possible, because a good part of what we're talking about doing here in accountable care is taking unnecessary costs out of the system. So one of the places, for example, where there's a lot of contracting going on now, and many of you may have heard this, is the idea of a shared savings program. So Medicare, for example, has a shared savings program in which Medicare assigns a population to a provider, and the provider says, okay, last year the rate of hospitalization in this population was X. And based upon our analysis, we think we can reduce that rate of hospitalization to a lower number, less than X. And that saves everybody money. So in exchange for me doing that work, I'm going to get a proportion of that savings. So that's a shared savings program. And so let's just say you could say we're going to take $6 million worth of hospitalizations out of the system. I may get $3 million of the savings as a provider. And I have to put new resources against that. And of course, what I don't want to do is hire a bunch of neurosurgeons or cardiologists to do this. I really want to do it with a more effective and efficient mechanism, and we'll talk about that in a second. Is that okay, Cindy? Am I doing all right? Okay, good.
Yeah, definitely. And everyone on the call, we will have time for Q&A at the end of the webinar. We've allotted a good 20 minutes or so to go through some audience-provided questions. So thank you for that nice broad overview. In terms of patient focus and value-based care, what are we as care providers, what are we held accountable for?
Well, this is very interesting because there is not one set of things we're accountable for. So what you're accountable for depends on two things. Number one, it depends on the population. And number two, it depends on the contract. So for example, and I'm going to refer to the Medicare Shared Savings Program a lot here. I use it as an example mostly because it's one of those programs that almost everybody in the audience will probably have heard of at one time or another. But there are both government accountable care programs and private commercial accountable care programs. And in general, there's about 5 categories, but again, some of the times some of these categories can be very different. But in general, there's 5 things that we're accountable for. One is quite obviously condition management. How are our diabetics doing? Number 2 would be risk reduction. So we want to prevent people from having to be admitted to the hospital with stroke. So therefore, we want to look at all of the stroke precursors like blood pressure, and we want to be able to not just say we did blood pressure control, but actually account for the fact that less than 9% of our population has a blood pressure over 140/90. So it's a very quantitative accounting. Our report cards are very metric driven, but that would be a risk reduction thing that we're accountable for. Prevention, things like flu vaccines. And then, interestingly enough, more and more of these programs are looking at some of these traditionally non-clinical things like care coordination. So again, I'm sure we've all heard the buzzwords about transitions of care and rehospitalization risk. This is really a matter of how do you do the handoff between the inpatient service and the outpatient care for that patient. How can you reduce primary hospitalizations by providing a higher level of care? How can you reduce emergency department utilization? These will all kind of fall under the category of care coordination and patient safety. So this is a place where we're accountable. And then the caregiver patient experience is becoming increasingly important. And in the next couple of years, we're going to start to see, for those of you that work in hospital systems, you CAPS, the hospital quality, hospital patient satisfaction scores. Well, there are going to be ambulatory care patient satisfaction scores, CAPS, and these will be published. So more and more of the capacity of a provider to negotiate their contracts from a position of strength, to be able to say, I'm worth you paying me. Here's how much my patients like what we do. Here's how reliable we are. Here's how much. The reason I refer to in Medicare Shared Savings Program is they're actually in the Medicare Shared Savings Program, and a number of them are directly related to health education. One of them is health promotion and education, and there's a measure that people are held accountable for there. So while that's obviously pretty direct for what we're talking about today, you'll see a little bit, at least 80 to 90% of the measures the Medicare Shared Service Program have a component of allocation. So this is a general sense of the 5 categories.
Stephen, you're breaking
yes.
up a little bit. I just wanted to let you know that you're
sorry.
kind of coming in and out.
It's my so I'll try to. I'm trying to act like I'm in front of the audience. I wish I could see everything.
You're pacing.
Well, so in fact, again, these are kind of 5 measures, and on the other hand, a lot of them also depend on the population. So if, when taking on a population, you know, for example, that there's a particular risk factor in the community. I worked in an inner city program where we had a tremendous number of sickle cell patients in the community. So in fact, because there was a high volume of sickle cell patients in our community, we negotiated and asked for sickle cell disease as being one of our measures of the degree to which we could impact the community. So that's one place where there is some, I don't want to say flexibility, but some level of individualizing some of these contracts to the community that you're in. And some of these accountability measures are based upon the needs of the person contracting for care. So for example, when a large employer may choose to negotiate, they may make one, I'll take a simple one, generic substitution may in fact be a measure. So because that is cost-related measure, and plan sponsors want obviously people to get the best care they can, but they don't necessarily want to have to spend unnecessarily. So some of the commercial accountable care organizations have some of the cost-related measures, such as generic substitution. Or they'll say, last year we had an emergency room utilization of 57% in this population. We'd like to get it down to 40. That reduction, a whole host of patient-focused programs, then that's another potential accountability measure. So I left the financial ones off here, but as I say at the bottom here, how these objectives are organized, we're really in a new era, and a lot of what is happening is very fluid. So over the last 3 years, as their ACOs, we've seen some subtle changes year to year in what some of them, as
Great.
people learn.
Great. Yeah, no, thank you. So can we kind of transition from what you've just staged there into how population management actually works?
I'm glad you picked this one, because you hear the phrase population health. You hear the phrase population health a lot, and depending on who's saying it, it has a different meaning. So when the really sophisticated clinical analytics people say it, they're talking about ability to do, for example, predictive modeling of population. And when the patient portal, they talk about. And so what we've done at Clinovations is we've come up with basically an operating model for population management, a universal operating model for population management. And there are 7 or 8 elements to this model. And when an organization chooses to take on population management, they have to, in one way or another, fulfill each of these requirements. So you need data, whether you're going to use clinical data, or as you'll see later, health literacy data. The kind of data to be used is depending on the organization itself. And again, the analytics platform, or how population surveillance takes place, how segmentation and targeting is done, what the outreach and engagement strategies are, or even something like, to what extent, what's the collaboration model in the organization? How do people work together? These are all things that have to be discussed and fulfilled. And I think when you look at it, really an opportunity to say, for everybody in the healthcare system, to say, where do I fit? What's my role? Can I make a contribution to any one or more of the functional requirements? And in this way, healthcare reform has really kind of changed the traditional boundaries between our roles and responsibilities. I was a vice president of a large hospital system a couple years ago. It's 7,000 employees, 4 hospitals, 30 physician practices. And most of these organizations that were part of the network had been acquired through acquisition. So there was a base hospital that was the original hospital, and then they bought one in the suburbs that had been owned by somebody else, and then a local community Hospital actually went bankrupt, so we acquired it and turned it into an urgent care center. I mean, the kind of stuff you hear all the time. But when I joined the organization, I was hired to create a single sense of purpose among all of these organizations. We called it enterprise focus. And we would go around and try to get, because one of the things that happened was all of the 30 doctors that in their individual practices, they all kind of thought they were still in private practice, even though they were part of this bigger network. So we really tried to get people to have a sense of, where do I fit in this? And one of the exercises we did there was to ask people, who do you depend on, which people love saying. Oh, I depend on these 5 people. If they don't help me, then I can't get my work done. But then we asked them the opposite side of the question, which is, who depends on you? And it was a very interesting exercise to take the entire organization through the idea that other people depend on you, and therefore this goes both ways. And we really were able to break down some of the traditional boundaries in the hospital. And the only example I want to give is, all of a sudden, the librarian, who had been a librarian for 15 years, and had been in the library and was doing really good library work. I mean, she was a well-respected in her community. All of a sudden, the librarian became part of the operations leadership team, because everybody discovered that to some extent they were dependent on the library, but no one had ever acknowledged it. So this was, I think what we're seeing here with population management is there's really a sense for people to say, yes, I have my job and I have my role and responsibility in what I've traditionally done. But in population management, there's an opportunity for me to contribute. And I'll show you a little bit later as to where this might work. So let's see how. Let's move. Did I answer the question, Cindy? Did I get to that?
Yeah, I think so. You know, I think you've opened yourself up to a lot of Q&A at the end by fessing up to your prior history. I'm sure people have a lot of questions for you. So yeah, we can move right on into we sort of had this view, and then I think we wanted to talk a little bit about allocation of resources.
Yeah, this is an important transition, and let's just say you put in that model we just saw, that operating model, you know, fulfill those functional requirements. Now we've got to figure out what to do with patients. Traditionally, a lot of the accountable care organizations look at the, quote, most expensive, the high users, the frequent flyers, those kinds of people. Again, the people who are chronically readmitted. And you can move on from this side pretty quickly, Cindy. Basically, that model doesn't necessarily work from the perspective of care planning. And I think that's where things are changing, because there's a traditional view of how to make a care plan, and then there's the way we have to start to do it. So let's move on from this one. There may be a little build here we can.
Okay, so we'll just kind of shift over to the resource allocation,
yeah.
which
so,
is, you know,
so
one of the key
traditionally, questions. Yeah. So traditionally, you know, medicine, doctors, hospitals, we take care of disease conditions. We do some risk reduction, and then maybe some prevention strategies like vaccines. And again, I have to admit, I'm a physician, I can make this admission. Wellness, not so much. You know, it's important. I'm glad other people are doing it, but I was a pediatrician by training. I got a waiting room full of kids I got to take care of. So, you know, wellness is important, but vaccines are good. I'll do my prevention work. If I've got a patient who's got diabetes, I'll make sure their blood pressure is in, and I'll take care of them. So basically, what you see here is, you know, the primary care docs kind of took an across-the-board look at prevention, risk reduction, and condition management. For risk reduction and condition management, we needed to bring in some specialists, and then if the patient was really sick, we hospitalized them. But that was the whole team. Do this slowly, Cindy. Let's do one at a time if we can.
All right. Whoops. I'm trying to.
But under pop health,
go backwards.
That's okay. Just put it in. Under population health. Yeah, do the whole thing. So under pop health, we need to add an entire new group of resources before the patient even sees the doctor, because physicians. The phrase that's used right now is people practicing at the top of their license. So in nursing, for example, and I think this is a great example, the degree to which we allow nurses to actually touch patients and take care of them is a much better and more efficient use of nursing experience and view of the patient than having them do administrative work at a desk. So to the extent that we can move the patient to a lower level of resource and, more importantly, and still achieve the quality objective, that's the critical piece. It's not that we're just trying to reduce how much we spend, because we have to hit the report card. But if we can make our marks on the report card and use a lower level resource, everybody wins. The patient gets their clinical objectives met, and we've saved resources for far more complex and intense patients. So let's just start at the bottom of this list. You know, we've got wellness, prevention, risk reduction, and condition management. Imagine if we could take care of every patient through self-management. Well, we will have saved a significant number of resources. We will have not required, the staffing and the buildings and the technology. But of course, we know that's not possible. We cannot do all of this with self-management. But the second tier is education. So imagine now we can start to achieve some of our wellness, prevention, risk reduction, and condition management objectives through education alone. And I submit that there is a subset of every population for whom education will be sufficient to meet the quality objectives. And then, of course, if not, we then may move up to what's called a health navigator or a coach, and then home care, and then maybe a nurse care manager. And only then, once we've gone through this escalating list of resources, will we determine whether we need to actually bring a physician into the group. Because we want, number one, we want to save professionals for when they're absolutely required. And number two, we've learned that some of these other resources, education, coaching, home care, can be just as effective to achieve many of the quality measures. So now we're reducing the overall burden on the entire society for the cost of achieving quality, and we've achieved all that quality. So if you, I think hit one more. I think there's one more build in there. Maybe not. So the idea with once you have a care plan, as you saw before, once you have one of those care plans, we then slowly layer on resources based upon the patient's responsiveness to achieving or moving towards their quality objectives. And as you can see, I circled the education, which you'll see in a minute, really becomes the critical first step to achieving these quality goals. So let's go on to the next one. How are we doing on time, Cindy? You okay?
I think we're doing okay. I am here. I'll switch to the next section, and so we can drill in a little deeper on your circle there. Where does patient education fit in?
Right. So there's two ways to look at this, and we're going to look at this from the perspective of that infrastructure I showed you: data, analytics, reporting, population surveillance, those functional requirements. So let's just look at data. Right now, when you talk to people running ACOs, when you use the word data, they think clinical data, lab results, medication lists. If they're working with an insurance company, there might be claims data involved. If they're working with their EHR vendor, they may be trying to extract data from the EHR to do analytics. But in fact, for population health to work, there's some other data that we need to have. And these are examples. I'm not saying these are everything that should be, but I think some level of assessment of a patient's health literacy and some level of assessment of the patient's level of activation or engagement will very quickly become critical success factors for whether the population management program will work or not. Because if you can say, a little bit downstream when we get into stratification and targeting, I know this patient will in fact be responsive to audiovisual communications more than text. Then you can target the intervention using what we know about the patient. So just like we used evidence-based medicine to determine their therapy, we used evidence-based communications to determine the most effective communication strategy or education strategy for that patient. And on the patient activation side, many of you may be familiar with something called the patient activation measure. It's a 13 or 15 question survey, which kind of gives you a sense of where the patient is in terms of their ability to self-manage. But these kinds of tools are far more familiar to the patient education community than they are to the clinical community, and the degree to which you all can help the people putting these population management systems in place understand the value of saying, oh, this patient is so active, I can actually predict that they will respond to an educational intervention, and you really don't need to give them a care manager. That becomes a very, very valuable set of insights. So just on the data side alone, and I think there's probably many more that I'm not familiar with, but the degree to which there are educational assessments by which that data can be used to come up with the strategy for the patient is very valuable. Analytics and reporting, obviously predictive modeling. And when I say predictive modeling, you say to a clinician, they think, oh, you're going to predict decompensation from congestive heart failure. I'm saying, I want to go back to what I said before, predictive modeling. I can predict this patient will, in fact, have a high-level response to an audiovisual learning opportunity. Can you use educational tools to look at patient response rates and engagement? Can you segment people by literacy? Can you determine education planning based upon data? Is there a contribution that patient educators can make to the communications plan as part of outreach and engagement? I'm sure many of you have been involved in helping build patient portals, but now there's multiple portals from multiple places. I think the insights, you know, when I went to work for the New York City Health Department, and this is not my policy, I'm just simply reflecting something I was told, and this is a long time ago, it was in the 80s, we were told everything to the general public is written at the 3rd grade reading level. And everything that's written to the professional community is written at the 5th grade reading level. And everybody looked and said, why would you write to doctors at the 5th grade reading level? And the assistant commissioner in charge said, I'm not saying they can't read something more complicated. I'm saying it's so easy to read, they're more likely to get the message because it'll be so easy to read. But it was a very interesting strategy. You could have probably taken that to the 8th grade reading level, but the point is, and we followed this up with evaluation research, when you did write between the 5th and 8th grade reading level for physicians, they tended to scan the document and remember the message, as opposed to scan the document and not know what went on. So these are all tools in my simplistic mind here that I think could contribute to the patient-facing side. And then, of course, care planning. You know, as part of the care planning process, you'll see in a minute that there are very specific. You've got some examples there at the bottom. The Medicaid ACO measure 2, 5, and 13, 2 and 5 in particular, how well your doctor communicates. Gee, can we help doctors communicate better? Is there something using patient education materials? If we simply had the doctor write, you'll see in the right-hand corner there, if we simply had the doctor write, quote, an information prescription, not my term, it's been used for a long time, but it takes on new relevance when you've got a population that you're working with. And if we could use information prescriptions as part of population medicine, now all of a sudden we've closed a little gap between patient education resources and clinical resources, and it helps the doctor get their rating higher because now the doctor's saying, you know what, here's something that you can learn. It's not coming from another source. And then obviously things like fall risk screening. These are places where education is in fact the intervention. So let's go on to the next.
Okay, it's quite a chart. Okay. Sounds like we may have lost Stephen there. We're having a little bit of a technical difficulty. Oh, there you go. Now it's telling me I've been disconnected.
So not meant to be read, okay? Actually, if you hit the next button, I think there's some red circles there. So there are 33 measures for the Medicare Share Savings Program. And at the end of the year, all MSSP programs, and there are probably 200 plus around the country right now. Again, I'm sure many of you are working at organizations that are connected in some way to an MSSP program. 33 measures, and some of them, 2, 5, are directly related to communications and education. So, in fact, 5 is health promotion and education. But more importantly,
sorry about that.
Yep, that's okay. More importantly is, of these measures in my assessment, of the 33, 27 of them are potentially facilitated with an educational component of the care plan. So whether it's readmission prevention, whether it's primary admission prevention, whether it's medication reconciliation, whether it's the value of some of the preventive health elements, or whether it's the learning that's required to achieve some of the risk reduction strategies, I think there's a place here where the foundation of the patient's care plan actually starts with the educational component. And then once that educational component is completed, or is in motion, I should say, not completed, because it's never complete. This is an ongoing process. But once that educational component is initiated, within a short period of time, you can assess whether that patient is making progress towards goal. And if they are making progress towards goal, then that actually requires a lower form of resources provided over that patient. But more importantly is, once the educational component is in motion and you assess that patient for progress towards goal, if the patient isn't making progress towards goal, that could become a trigger for additional resources, whether it be a navigator or a care manager or actually requiring a physician visit. This is really an important foundation. So you test the population. You test your diabetics who need to have better blood sugar control by giving them an educational program and then seeing have you affected any change. If you've affected change in that audience just from education alone, then you can back off for a while on that group and focus your attention on the group that really didn't show any progress. And it allows you to much more effectively and support some of the primary goals of accountable care, which is, again, to use the least effective resource to achieve the goal. And I think that's probably where I'd like to stop and see if we've got some questions.
Yeah, so anyone on the call who would like to ask a question, you can either shoot it to me in the chat forum, or there's a Q&A box as well. We do have a new poll that was posted just to get a sense of what folks are using in terms of patient education and delivery systems. So, you know, we might be able to incorporate some of that into our answers as we know where people are coming from. Okay. So I have one question here.
Sure.
Can you hear me?
Yes.
Okay, fantastic. So in your experience, have you had much work with delivery models for patient education platforms and things along those lines? So someone is asking, what's the best delivery model for the education that you've seen?
Yeah, if I had that answer, I would start a company. But no, it's actually it's in a very that's actually I'm joking, because it's a hard question and it's a great question, and it's actually made more complicated right now because more and more components of a patient's healthcare system are trying to drag them into patient portals. So you've got patient portals attached to the electronic health record. You've got patient portals attached to the payer or the employer. You've got other patient portals that are freestanding, like the Center for Medicaid Services physician scores. I have to say, largely from my training, but also from my experience, you need to assess the communications opportunity really, unfortunately, on a patient-by-patient basis. People may have internet access and they still may not go to a website. We've seen with the older population, many do have internet access, but they use it in such a way that some of the more interactive portals don't work for them. They actually still prefer old-fashioned telephone. Mm-hmm. So we as a community have to start to really figure out ways to simply and easily assess for any one person what are the optimum delivery mechanisms for that person? And by the way, sometimes it's not asking them. It might just be asking them, but sometimes it's not just asking them. Sometimes there's other ways to kind of figure out how they get their information and then shape our delivery strategies around that. I was very recently involved in the design of a very sophisticated portal. The portal was attached to an analytics platform. The patient's gaps in care were delivered directly to the portal. Lab results were available through the portal. The patient could make appointments and communicate with their care manager through the portal. And adoption rates ran 9 to 12%, depending on the population we were working with. This is a very exciting, state-of-the-art piece of technology. But again, very low engagement rates. And I think while technology is very valuable for a subset of the population, I don't necessarily think it's the only way people get their information.
Yeah, and from what we see on our side, yeah, I hope so. I think it was thorough. Well, and what we see on our side as the content provider, we're integrating into all these various platforms, is that a lot of it's dependent on budgets internally, the staffing capability of what they can add to their training load. If they've just implemented an EMR, do they now need to go back and learn a separate patient engagement platform, which may be too much all at once. So we're seeing a lot of different things that are driving the implementation side. Certainly, as you mentioned, the patient-by-patient basis, what are the patients capable of absorbing? But the exciting thing is that the new technologies are allowing a lot of engagement opportunities. So, we're able to connect with people through a multitude of devices, platforms, locations, kiosks, digital signage, you name it. And it's really putting the information out there in a way that wasn't possible before. Certainly reaching people at home in a much more dynamic way. For the most part, now, we recognize that there are some population groups and patient sections that aren't as technologically connected, but we hope that they have care providers or family members that are able to reach out to them and kind of bring them into that connected component of providing the information wherever and however they might need it. So we have another good question that came in. Stephen, you mentioned PAM for patient activation. What are you using to measure the patient engagement? And then how are you defining patient engagement?
Oh, good question. So there are a number of tools that allow patient engagement assessment, but in fact, what we're using as part of our consulting practice at Clinovation is one that I developed in a prior role I was in. And let me see if I can find it right now on my screen. I can tell you a little bit about it. But basically what we do is we look at the extent to which someone had, let me step back for a second. One of the things that I discovered, I was working with a care manager, a care management call center. And the gauge of the care management call center's success was, when I first started to work with them, was how many connections did you make? So how many times did the patient answer the phone? And it didn't judge in any way what the interaction between the care manager and the patient was. It was all a matter of, did the patient answer the phone? And then the plan sponsor for that particular insurance plan, because this was part of an insurance plan, gave all the patients that were eligible for disease management an incentive for talking to the care manager. But since the report card only had to be number of times I spoke, the employees very quickly figured out I just need to answer the phone, have a brief conversation, get off the phone, and I get my incentive. So we reconfigured that. It wasn't just, did you make the call? It's, did you make the call, and was there a substantive, clinical objective-related conversation, and what was the objective? And so we started this, we kind of worked on this gradated engagement model that was not just about did you connect, did you connect, then what happened? Or did the patient themselves reach out? So a patient who actually makes an inbound call is ranked differently than a patient who only takes the outbound calls. And You know what? If we're going to have a handout, I'm happy to include this in the handout because, you know, it was work that was really kind of grounded in reality. It was not, you know, like PAM is a validated measure. This doesn't come close to that, but it's a very practical way of saying, oh, we have X number of patients who are fully engaged, or, you know, low level versus high level engagement. It's not easy right now. A lot of this stuff is not as well defined because we're, you know, this whole issue of managing populations at this level and collaborating with this level of care is really new for all of us.
Okay, great. Another question that came through in regards to health literacy. Is it beneficial for administrators or staff to undergo health literacy trainings? Or should organizations assume and alter all patient education to third-grade reading levels? Is this something that can significantly help increase patient experience and patient understanding? Or could more be done to ensure positive patient experiences? So I'm sure we can both comment on that. Why don't you start?
No, that's a great, very, very important question. I think, and I would answer it two ways. Number one is, no, I don't think everyone needs to be trained. I do think that everybody needs to understand the principles. So, and I'll give you an extreme example. When I was at the hospital system, I had a long conversation with our CFO about health literacy. And he truly had never really had that level of conversation. I mean, he had heard about it, but he didn't understand how it was relevant to what he did as the CFO. And I was able to show him that there could be a direct relationship between our capacity to be more sensitive to health literacy issues and one of his big measures, which had to do with patient loyalty and steerage. So the extent to which patients who lived in our catchment area, in the geographic community, were dividing their care between some of the other same mark. That he got, and all of a sudden at other meeting about our health literacy component, by showing him where this concept could support his objectives as an executive, I was able to kind of get him on board. Now, it didn't necessarily get us more budget, but it got us more share of mind in the organization, and that would ultimately lead to budget, just not right away. As people began to say, I need this, I need this, I need this, it was easy to say, oh, we need to expand some of these measures. That's answer number one. Answer number two, it's very, very hard to have that universal set of materials because you have such diverse populations in terms of their educational level and interest in health issues in general. So I don't think you can quite customize health literacy to everybody, but I do think you need a diverse set of tools so that you don't deliver something to a college-educated patient who thinks it's too simplistic and therefore I'm going to dismiss it. And at the same time, you don't deliver something complex to a patient who is allowed to even say, I don't understand it.
Right. Yeah.
A personal example of that is when my wife delivered our son, the anesthesiologist turned to her and said, I'm going to give you a bolus now. And she just sat there, but then when the anesthesiologist left, she turned to me and said, what's a bolus? And it was a classic example of that disconnect in language, but this guy's got a catheter in her back, and she's not about to say, what is that, as he's doing it. So it was really an important lesson for me in terms of the importance of communications and language that we use.
Yeah, definitely. And certainly from the content production side, the health literacy component and the adult learning styles are factored into all of the productions that we're creating. And we've done a lot of that due diligence on the upfront for our content so that everything is scripted at a 6th grade level or lower. That's the threshold that we're using, 5th to 6th grade level. There are some terms like glucose and insulin that you just can't get around, and that'll spike up your literacy levels. But we make sure that that terminology is defined in very easy to understand concepts and language. The other factor in the health literacy is a lot of times we're dealing with patients who have English as a second language, or you know, they may be very well educated, you know, with master's degrees, but not necessarily understanding the medical terminology or the medical implications of, we see it every day, you know, medication interactions, you know, why you need to do certain things prior to surgery. If it's not explained, it's easy to non-comply because they don't have that background information to drive the necessary things to move it forward. So those are some of the things that we make sure to incorporate in their scripting. And then the multimodal learning techniques, you know, we know people learn differently, so we have to represent things graphically, we have to represent them in terms of modeling behavior, we have to represent them in a sort of text format, and video sort of lends itself to the ability to kind of display things in a multimodal way. So I hope that answers the attendee's question there. We do have a white paper posted on Milner-Fenwick's website that will drill into some of that health literacy topic even deeper, and we'll cover it to a degree in a new white paper that we'll be releasing to follow up with this webinar on accountable care. So feel free, they're free white papers. It'll kind of drill into that health literacy component a bit deeper than we're able to today. Stephen, there's another question here about the instrument that you mentioned, whether that is available or when it will be available for dissemination.
Which one? I mean, my little patient engagement ranking tool, or the PAM?
I think the ranking tool. It doesn't specify, but I would assume that is.
I'll bundle it into whatever handout we're going to have associated with the webinar.
Okay, fantastic. Fantastic. That is great. How are we doing on time here? We've got about 5 minutes left. We can probably fit 1 or 2 more questions in. I have a question here just around what are some of the reasons that ACOs struggle or fail? Trick question,
well,
right?
you got an hour, because that's a long one. But let me give you the quick answer. ACOs struggle or fail for, I'm just going to give 3 reasons. There's many more, but I'll give 3 good ones right now because we only have 5 minutes. Number 1 is they only focus on the quality measures. So you've got a contract, it's got 33 measures. I'm going to focus on 33 measures. And you don't realize that there's you don't invest in the other things going on with patients. So, for example, you know, you may have a whole host of patients who have atrial fibrillation and are not on anti-stroke therapy. Well, if you look at the MSSP measures, there's nothing for atrial fibrillation. So, patients have strokes because they're not adequately they don't have sufficient antithrombotic drugs on board. And now, you know, these are devastating events, and you're just going off the roof because you haven't looked beyond the quality measures. Every patient needs a care plan. Every single patient needs a care plan. Even if the patient is completely healthy and just has well in their care plan, every patient needs a care plan. Because once they have a care plan, they're on the radar screen. And once they're on the radar screen, you can track them. And that's population health. So year 1, inevitably is complicated because you've got a whole bunch of patients who've been out in the world and not getting care, and you can overinvest in that group to get there at a certain point. That's number 1.
You're breaking up a little on us.
Okay, sorry. So number 2 is people focus more on the analytics and less on care management. And I think our health system, and I'm as much a part of this as anything else, doesn't quite understand the concept that we just went through of that escalating levels of service. You know, they still start with nurse care managers as the baseline level of intervention because the systems aren't organized to deal with non-clinical care to achieve those objectives. And then the third piece is care planning. It's kind of connected to the first, but care planning. The framework for care planning is not well integrated, so it actually comes down to much more of a coordination problem and a collaborative care model. I often say one of the problems with physicians in teams is you don't really do a lot of team projects in medical school. And a physician's view of their role on the team is usually that of team leader, and yet in these systems, there's a really flat, there's no hierarchy on these teams for accountable care. And it's a process by which we are kind of re-engineering the way people work. So those are 3 reasons why people struggle with accountable care right now.
Excellent. Great. No, I think that was very helpful. Okay. Well, I want to thank everyone for joining us. We will be sending out some follow-up information. And as I mentioned, Milner-Fenwick will be releasing a white paper on education within population health and accountable care that will dive deeper into some of these topics. If you have questions for Steve Merahn, his contact information is up here on the screen, and it will certainly be included with the follow-up information as well. And if you have questions for Milner-Fenwick, hopefully you all have your account representative information, or feel free to reach out to me directly. My extension is 207. And again, thank you all for joining us. We had a great group of attendees today, and thank you, Stephen, and the team at Clinovations for joining us.
Thanks for everybody for taking the time today. It was great fun for me to take this time out of my day.
Fantastic. Thanks. Take care, everybody.
Bye.